that the AVP neurons are widely spread, the supraoptic and the paraventricular neuron, and these neurons then converge. They continue to travel to the posterior pituitary, which we discussed earlier also, through the pituitary stalk, and 5% of them are terminating in the median eminence. So if you have a lesion in the pituitary, your pituitary is knocked out, you will not have diabetes insipidus because some amount is already there in the median eminence. So you have got two types of AVP neurons, and I talked about that. One is the magnocellular, which is the large one which we talk about in terms of water regulation. You have got parvocellular also, which are mainly regulating the ACTH release, which I talked a bit earlier in the HPA axis, and both becomes important. So for a hypothalamic lesion to cause DI, you need to have a large lesion. It has to be spread over a few centimeters. The classical example of that is craniopharyngioma, or you have got a brain death DI, in that you've got a complete destruction which happens of the gland. That's how it will present. However, if you have a small lesion, which may even be missed on imaging, which may cause this problem, this could be at the level of a pituitary stalk. The classical example of this will be a germinoma, which is going to cause this scenario. A pituitary lesion will never cause diabetes insipidus. If you have a predominant pituitary involvement with diabetes insipidus, you're looking at, so either a lesion is starting here or going up, or more likely you're dealing with an infundibulohypophysitis, in which starting from anterior pituitary and then your posterior pituitary is getting involved or damaged. Otherwise, plain pituitary lesion will not cause DI. So if you remember this child, this person whom you're talking about, you said the primary problem was the visual complaints and there was no DI. So this is going more in favor of a cellar lesion. While if you have a primary problem of DI with no visual complaints, you are more likely to be dealing with a supracellular lesion. Now, AVP we have discussed is basically the arginine vasopressin, or an antidiuretic hormone. So its main role is to prevent diuresis, or I would say more precise role will be anti-aquajuresis hormone. So it should be AAH. It is not diuresis, because diuresis means sodium and water both. This is mainly for water loss in that regards. So it is produced again, like many other compounds. We talked about pre-pro-insulin, we talked about POMC, we talk about GnRH, all of them are pre-pro. So this is also a pre-pro compound, which is then converted into three major parts: the AVP, the neurophysin, and copeptin. What is the role of neurophysin in the whole process? So AVP, will it be produced when you need it, or will you keep stored? Yeah, so now answer the second question first. Would you want to keep your AVP in store, or you will produce when you need it?
Then we'll keep it stored, sir.
Because it is going to take such a long time. It's a large molecule. And then once you keep it in store, you need to put it in a vesicle. And therein, as you were saying, neurophysin plays a role in packaging that. So if you have a neurophysin defect, what will it present like? Milder, and more importantly, a later onset. So it will be a two-hit model. The first hit model will say, okay, the production of vasopressin is a bit less. The second is that because of this misfolding, your cells will damage and then you will have a later onset DI. So classically speaking, this is a very, very important point I'm saying, is that isolated central congenital DI is extremely unlikely. If you have a central DI right in the early age, you're dealing usually with malformations. We're talking about Hessex defect, septo-optic dysplasia, child is having a lot of problems. After that, if you have no other extra pituitary manifestations in pure DI in the first 1 year, you are thinking of which form, central or nephrogenic? It is mainly nephrogenic. So a normal looking child, especially this male child, presenting to you at 6 months to 12 months of age with low-grade fever, dehydration, developmental delay, hypernatremia, it's mostly a nephrogenic DI. This form of DI is going to present only around 1 year, 2 year, 3 year. That sort of, it's a much later presentation from that perspective. So now you have got two things. You've got the AVP and the copeptin. Copeptin, like C-peptide, is a marker of AVP production. And now there are assays available. A lot of people are now using it as a marker of differentiating central versus nephrogenic. And this is a big issue often which we see. We talk about water deprivation test, and then we say you give a AVP response, there will be a response to that. But that's not always as easy as we talk about. So if you can really measure copeptin, and copeptin is low despite you being dehydrated, it is a very good marker that there is a problem in the DI in that perspective. Something like that, your cortisol is very low and your ACTH is still low. So this is like a central cause. You will get the idea. Or if you say that, okay, your sugars are high and your C-peptide are still not high, it means that you have a problem in insulin secretion or insulin production in that perspective. So copeptin is a marker. It is produced in equimolar amount as your AVP, and it has a much longer half-life. AVP will be destroyed within minutes because you have got a vasopressinase which is present in that regards. Now, the most important regulation which we all talk about is osmolality. So if your osmolality goes up, your organ vasculosum lamina terminalis and subphonical organ, the osmoreceptor of them will sense it in that region and it will say, okay, now we want to have AVP coming into the picture. The normal osmolality, if we say, is around 280. As soon as it goes beyond 283, you start having the change. The peak change happens by around 294 and 300. Definitely, you should have the maximum amount of AVP, which happens. Peak is around 290, and it may go up to 10 to 20 picogram per ml. For every 1 to 2 rise, you get around 1 picogram per ml rise, which is going to happen in that regards. Volume is a regulator, but it is more of a modulator. What do you mean by modulator? If you have somebody who is having dehydration and his osmolality is 286 versus somebody who has hyperhydration and osmolality of 286, who will have more AVP? Yes, because that will multiply your effect. So it's more of a modulator rather than a primary cause, unless the dehydration is very, very severe. So if your fluid becomes less, your carotid sinus and the atrial stretch receptor will say, okay, this fellow has got too little fluid. It will then act via the NTS, the tractus solitarius, which is going to start acting, and it will say, okay, produce more AVP in that regards. It is not going to be there below 8%. It's going to peak at 25%. So this is like a dying response. If you look at the sort of our strategy in terms of vasopressors, what is the usual sequence you will start off in somebody who has a septic shock? Which one will be the first, which will be the second, third, that sort of a thing? Adrenaline, noradrenaline, dopamine, and then vasopressin is the last. So what does it mean? Vasopressin is a very, very potent. I think if I'm not wrong, this probably is the second only in terms of vasoconstriction compared to angiotensin 2. So it's a really, really strong vasoconstrictor. But if you do a lot of vasoconstrictor, your splanchnic circulation will be, so it will say, okay, I'm just caring about the brain. I'm caring about the kidneys. I don't worry about your gut. So it is going to be there, but it's going to be there at a very, very late stage. So you can say 25% loss, which means somebody is dying. Then you will have huge amount of vasopressin, and the levels there will be 10 times what you achieve from a normal individual. So when you have somebody with diabetic ketoacidosis, and going the other way around to correlate it, you will have high levels of cortisol, epinephrine, and AVP. So if somebody with what will be the blood pressure in somebody with DKA? Normal, or if at all, it may be high also. But if you have somebody who has shock and DKA, what does it mean? So very, very severe infection, lactic acidosis, multi-organ dysfunction. So anybody with DKA should not be in shock, because your vasopressin is also very high. Vasopressin becomes high in this thing, and which contributes to hyponatremia. So hyponatremia, the RAS axis causes hypokalemia. So both of them are contributing to pathophysiology, but that prevents your blood pressure from going down. So that is why if somebody with diabetic ketoacidosis is in shock, you should be in more shock that there is something grossly wrong in this child. Correct it, otherwise he will pass off very quickly. So this is how the AVP is regulated. There is also the effect of other non-osmolar signals which you need to be aware about. Of course, if somebody has vomiting and nausea, that can really do a lot of concentration in that regards. Nicotine, caffeine. So all these intakes should be avoided when somebody is going for a water deprivation test in that regards. If somebody is severely nauseated because of dehydration, you may really have a lot of vasopressin which can come up. So if somebody has a nephrogenic DI, and if you get all these things and your AVP goes up, so maybe you are above the threshold of resistance and you may concentrate. So just because of that, you cannot exclude that this is not a case of nephrogenic DI. Now, I already have told you that AVP increases, ACTH increases cortisol. So the other way around, in a hormonal axis, you can't have a one-way phenomena. You need to have a feedback inhibitory phenomena. So cortisol is going to clearly inhibit your AVP. If your cortisol level is more, AVP will be less. But what I'm more interested is that if you have a cortisol level low, your AVP level will be high. So if you have somebody who has a cortisol deficiency in the setting of a multiple pituitary hormone deficiency, what will be the impact on its manifestation of AVP deficiency?
Cortisol deficiency will lead to
So you will be masking diabetes insipidus. So if somebody has no cortisol, one, free water excretion is also defective. Second, AVP, whatever some amount you are producing, you will produce more. So you will have a DI minus SiADH, which is 0. So it will mask your DI. As soon as you replace the cortisol, you will start having polyuria in that setting. This is very classical in the setting of a craniopharyngioma follow-up in that regards. Now, AVP is degraded via the enzyme vasopressinase, which is basically a very, very fast acting present in the plasma. And that in a way is going to regulate an important part in that regards. Now, vasopressinase means that if you want to give AVP, it is not going to work for a long time. So either you use as an infusion or you use analogs of AVP which are resistant to vasopressinase. The classical example is DDAVP, desmopressin, which has got specific deamination occurring. We'll talk about that when we talk about the management of DI in detail that happens. Now, vasopressinase is produced by which tissues? Or expressed where? Most of these enzymes are expressed where? Liver. And when there's liver and placenta. So placental vasopressinase is very, very significant in clinical perspective because during pregnancy, you will have more vasopressinase, meaning so if there is a X-linked form of nephrogenic DI, the child is affected, but the mother may be normal because they have got enough vasopressin to take care of it. Their activity 50% is there. But if you have got more vasopressinase activity, that is going to cause DI precipitation during pregnancy. So this unmasking of carrier status resulting in DI may happen in the setting of a pregnancy in a nephrogenic DI in that perspective, and that becomes important in that regards. So now we've talked about AVP as a major regulator of the osmolality, quote unquote, sodium, which is the major aspect from that regards. And this we've discussed already that normally if your osmolality is around 280, you do not have any AVP secretion. Around 283, you will start with 1. And as the level go up to 300, 290 is the maximum. Around 295 to 300, you will have a level of around 10 in that regards. So this gives you an idea as to what is your goal in terms of achievement in terms of your osmolality in a water deprivation test. So we talk about figure of 300 or a serum sodium of 146. How does it come from there? Here. If your sodium is about 46 and your osmolality is about 300, you have no business of not having such a high level of AVP, which is then going to saturate its receptor. So AVP is starting from there. It's a highly sensitive 1% change is going to be there. There is of course a set point to that. Like there is a set point for temperature, there may also be a set point for osmolality. Which physiological conditions can alter this set point? So if your set point is altered, like we talked about calcium sensing receptor, your calcium may be set to a lower or higher level. When your set point is shifted towards the left side, you will have predominantly hyponatremia. When it's shifted on the right side, you will have hypernatremia. So which physiological situations will you expect hyponatremia or fluid retention or edema? Pregnancy. So pregnancy, of course, is important. So key regulator here is not really pregnancy, it's the HCG or LH. And LH and HCG act in pregnancy, and where else you have got a very high level of LH? Not puberty, during the ovulatory phase. So post ovulatory phase, you will have a lot of LH HCG, which will shift it towards the left side. I've already talked to you that hypovolemia is a modulator of AVP secretion. So hypovolemia will shift towards the right side, and that will give you a greater enhanced response of AVP. So pregnancy, of course, you will have a shift there, more fluid, more hyposodium levels will be shifted towards the left side in that perspective. Now, this is the other point which Dr. Sandeep already said, that the thirst mechanism starts activating 10 points after the AVP mechanism, and that's very, very important because there's no point then that you start drinking and losing. You'll only be passing urine all the time in that regards. But this both AVP and thirst, they are equally important and they can compensate for each other. So if you have AVP deficiency and normal thirst, can you develop hypernatremia? So only when which patients will develop hypernatremia?
Damage to the hypothalamus, not having thirst.
So thirst sensation is not there.
Surgery done.
So it's the same thing, na? Access to water. Somebody is nil per orally and you are not giving water, and neonates. So they can't drink water. So if that's again the access. So again, two things. If your thirst is either the center is gone, all your osmoreceptor, as you talk about adipsic hypernatremia, or you don't have access to water. In both situations, you will develop hypernatremia. Similarly, if you are having no thirst, the urine output will try to also conserve in that perspective to get you the right perspective. Now, AVP, the major work I said is to increase the permeability of your collecting duct to water. That's it, nothing else. So AVP is going to work via the V2 receptor, and there are a lot of receptors of AVP we talked about. V1 receptor, V2 receptor, V1A, V1B. So we'll talk about much more later on. So this is going to work via the V2 receptor through the cyclic AMP pathway, acting through the VAMP2 to cause the shift of aquaporin to the membrane. Just like your aldosterone shifts your epithelial sodium chloride channel to the plasma membrane. Now this aquaporin is just like a water canal through which all the water, so it's like dig hole and you get the water outside. So this aquaporin O comes towards the membrane, allows water to go inside these cells, and from these cells through the aquaporin 3 and 4, it is going to be shifted to the capillary. So you are effectively absorbing water. So if you got a lot of AVP, you will be losing less water, less aquuresis, which is going to happen, and the water amount will become less in that perspective. If, of course, your aquaporin is not working or your V2 receptor is not working, you will have losing a lot of water through your lumen from that perspective. A very important regulator here is prostacyclin in this pathway. So we already discussed that AVP levels start to go up as your plasma osmolality is going up. We need to also understand that how do they correlate with the urinary osmolality. So if you look at it, your urinary osmolality will basically decide about how much is your urine output. So I said your urine output can be 20, 10 liters and 500 ml, roughly. If you talk about 20 times, here we have took the extreme of 16 liters and 0.1. That's like an extreme. But the concentration I talked about is 4 times. Plasma is 300, you go up to 1200. Going beyond 1200 is not possible. What allows this 1200? What allows this 4 time constant? 4 times is a big number. Do you have an active process which is regulating this?
AVP.
AVP. Is there anything else which is more important probably than AVP? Is the counter current mechanism. What are the counter current mechanism? That is causing the medullary concentration gradient. What exactly is the counter current mechanism?
It's like sodium is absorbed and urea is absorbed in the medullary interstitium. It will increase the
From where?
From the Henry's loop. And
So you've got the descending loop of Henle, the ascending loop of Henle, and the descending loop of vasa recta and ascending loop of vasa recta. So you've got the blood vessel also going in, and that's why you've got 2 tubes going in parallel. So as the water, as the urine is going through the descending loop of Henle, this is permeable to water, not permeable to sodium. So what happens? Lower side sodium becomes concentrated. So this is 300, this becomes 1200. As you go up the ascending loop of Henle, that is permeable to sodium, but not permeable to water. The sodium is going to go out, again it becomes 300. Now this sodium is then going to go to the descending limb of vasa recta. So vasa recta will become concentrated, and once it goes up, it is going to excrete this sodium. So this counter current means 1, these two are 2, that's why your medulla becomes really concentrated. It becomes 4 times concentrated. If medulla is concentrated, of course, your urine will become concentrated. So this is very important. In long-standing DI, what is going to happen to this medullary concentration gradient?
Increase the medullary concentration, sir.
So
even we give vasopressin, sorry,
yes. So your vasopressin action is also dependent upon this medullary concentration gradient. So if somebody asks me one thing which is the most important, I would say it's actually the medullary concentration gradient. If somebody has long-standing DI, years altogether, no treatment, he will use everything to try to concentrate, and his medulla has also become dilute. So in that case, if you give AVP, he is not going to respond. And you may label, okay, this is nephrogenic DI. But then if you wait for some time, if you take a sample after 2 hours, if you take a sample after 4 hours, if you take a sample after 24 hours, you will say, okay, now the urine is concentrating. And that is why people have decreased the cutoff. Earlier, they used to say, okay, urinary osmolality should double. But now we say 50% rise is good enough. Because theoretically speaking, which is more common, central or nephrogenic? So your pretest probability is more. So if you are just saying, okay, I checked after 1 hour, urine osmolality did not go up, this is nephrogenic, then you are unnecessarily labeling. And getting a diagnosis of central DI is essential not only from treatment. 1 year treatment is very easy, while nephrogenic treatment is extremely difficult. So if you diagnose central, you know, I'll give vasopressin, he'll respond. But more importantly, there would be a CNS lesion which might be missed, histiocytosis which may be missed, sarcoidosis which may be missed. So that's why this differentiation is very important. Therein, this problem of long-standing DI is going to cause confusion. So always when you think of DI, making diagnosis, water deprivation, think in your mind, what are you thinking about? Are you really thinking that this is DI or not? Second, if you're thinking of central versus nephrogenic, if you think of central, then you can be more aggressive in terms of doing after 6 hours. And I've seen this in some patients, this can be a sort of a eye opening. The color will change urine and you will know immediately. You don't need to do any test. It was pure water and you gave, it became yellow. End of the story. But in many cases, you have to wait and watch. Wait till 24 hours. And sometimes some people actually say is that before you label anybody as nephrogenic DI, you give them a course of AVP for a few days just to make sure that they are not responding. I would not do that in somebody who is 6-month-old, who presents you with mildish level of hypernatremia 155, 156. There is a family history, there is a polyhydramnios, the mother gave a history of polyuria in pregnancy. But yes, in all other cases where NDI is less likely, it's always better to think of common things first before the rare scenarios and maybe give for a few days. There's no harm. What will happen if you give AVP to somebody who has a nephrogenic DI? Nothing. Their AVP is anyway high. What will happen if you give thiazide to somebody who has central DI? Will they respond? So we give thiazide amiloride for nephrogenic DI. Suppose you make a false diagnosis of nephrogenic DI in a case of central DI and you give them thiazide amiloride, will they respond? They will respond. They will respond because it's a distal thing. This is after the AVP action. So there will be some response, and then for the life you are going to say this is nephrogenic DI. So be cautious of the diagnosis of NDI unless there is a structural abnormality, unless there is a clear-cut drug which can cause that, ifosfamide, you know that this can cause that, or there is a genetic form which you are thinking of in that perspective. Now, just in the final sense, if we now combine everything, we know that as the plasma osmolality is going up, your urinary osmolality should go up. This is no particular logic, no great thing about that. Your urinary osmolality may be low if it's 280, but as soon as it's going about 290, 295, your urinary osmolality should be sky high. Everybody who has a concentrated blood should have a concentrated urine. Quote unquote, I can say 300 and above, it should be about 600. Generally, that should be the scenario. So this is a case of normal response, and if you give them AVP, what else will AVP do? You're already in a maximum AVP stimulated state. Just as a lot of people say, okay, this person has come to me with hypoglycemia, hyponatremia, his cortisol is low, I should do a ACTH stimulation test. Do you agree? Alapan? I'm talking about a different scenario. Somebody's come to you with a sodium of 100, glucose of 30, and cortisol is 300. Will you do a ACTH stimulation test? He is already ACTH stimulated. Here, he is already AVP, water deprivation is there. So there's no point in thinking of it. There will be no response to AVP. This is normal. However, if your osmolality is increasing, but the urine osmolality is not increasing, this is DI. There's no confusion about that. If you give, and there is a 50% increase, not a huge increase, this is complete DI, no response less than 50%, this is complete nephrogenic.